So next we'll welcome Dr. Tock-han Lim, who will be speaking on randomized controlled trial results versus real-world management of neovascular AMD in Asia.
Thank you very much, Chairman. I'd like to thank the organizer for inviting me to share a few points on challenges of real-world management of wet AMD despite the very good RCT results. This is my conflict of interest. So randomized controlled trial are based on well-defined patient population, well-defined treatment posology, strict patient adherence, but with limited trial duration, usually up to 2 years. In real-world management, we oftentimes have diagnostic challenges, double or triple pathologies, subtypes of wet AMD we have to work on. There are variations in posology and challenges in following up the patient, and we have patients with lifelong treatment. So take, for example, this type of VA curve, which is familiar to all of us. We see very good visual improvement in the first 3 months, followed by a stabilization phase, which lasts about 1 to 2 years. We've seen in all the agents that we know of today, but the real-world outcome is not as rosy. In Luminous study, the real-world outcome is increase of 3 letters from a base of 52 ETDRS letters. Now, why so? There are at least 5 reasons why we could not achieve the good result of RCT, and these the real-world challenges that I'd like to highlight with the use of a few case examples. First, diagnosis in Asia, pachychoroid is very common. This is a patient that's referred in after 4 aflibercept injection, but to no avail. You can see that this patient was treated for pachychoroid neovasculopathy because of the double layer sign. Now, we repeated the OCT angiogram, did not show a CNV. ICG did show a CSCR pattern and confirmed with the FA. So the good old single spot focal laser solve it. The second is the subtypes of wet AMD in Asia. As you know, about 30 to 40% of our wet AMD are polypoidal patients. Planet study has told us that anti-VEGF work very well for polypoidal patients. And in fact, Xalwin is now showing even better polyp closure rate of about 51% at 3 months. And Planet showed that aflibercept 2 milligram can close polyps of about 33% at 2 years and inactivate polyp of the 80%. So many of our patients are treated with anti-VEGF treatment today. Now, this is one example of pachychoroid neovasculopathy observed for 2 years and then turned exudative. You can see subretinal fluid there. And there is ICG proven PCV. This patient was treated with aflibercept, and 1 month after injection, voila, the subretinal fluid goes away. And we are about to celebrate at 3 months. However, after 7 aflibercept injections later, we could not extend the patient beyond 2 months. So at this point, the patient got very upset with me, and he wanted to stop injection. Now, this is the patient has got 2 stents in the heart and on double anticoagulation. So this is one patient that I really cannot leave an open polyp in the eye. So I bargained with him, said, give me one last chance. I'm going to do 1 treatment for you, and after that, we'll stop and watch. And this is the patient 1 month later after combination therapy with verteporfin and injection. Now, that brings to the point of Everest study that shows that combination therapy can close polyp at a high percentage and return better visual outcome compared to ranibizumab monotherapy. Now, this is one such patient enrolled in this study. You can see that this patient, after treatment, actually had quiescence for at least 6 years, and then At this point, 9 years later, without any injection, this patient suffered recurrence, and you can see that there are 2 polypoidal lesions out there. So if you don't throw away your ICG, you can identify where the troublemakers. You can do just low-cost focal thermal laser photocoagulation, and this patient is back on the quiescence for another further 2 years. So imagine this is 10 over years without single injection. So which are the patients that we need to select for PDT combination, and which are the one we go for anti-VEGF? I think currently many of us will start with anti-VEGF, and for those who are persistent, we go on to PDT. But notice in every study, the polypoidal size is actually twice of planet study. And therefore, for a larger polypoidal lesion, you may think about combination therapy first if you have access to the ICG and the verteporfin. Now, the other big problem is adherence. You can see that although in the well-funded study, well-funded countries, patients actually did not get the same RCT result as you would expect, and that's probably because of adherence. So other than dissatisfaction with VA outcome, financial burden is huge. And in Asia, if you look at the GDP map, you know that anti-VEGF therapy only benefit a small proportion of patients in Asia. Biosimilars are here, but they are not cheap either. But there are other factors, for example, difficulty to access booking appointments. If you have earlier heard Dr. Prasad mention about the percentage of ophthalmologists per million population, and in Asia, the number is far lower than Western countries. And there are patients also having injection fatigue, even if they have the financial means and have the access to ophthalmologists. Many patients end up with tiredness of continuation of treatment. This is where new long-acting agents such as Vericimab and aflibercept 8 mg hold promise, because you can achieve the injection interval of 3 to 4 months in about 60 to 80% of patients, which means the patient only get to come back for about 3 to 4 injections per year at fairly fixed interval. Now, the last to discuss about the challenge is long-term outcome. You may get very good result in the first 2 years, but going on, studies after studies has shown that vision start to drop back to baseline and then go into negative territory beyond 4 years. And one such condition is paradoxical response, which you would see in about 4% of your patients, especially those long treatment patients. Now, the other problem is GA. You can see the GA appearing in front of your eyes, as shown in these scans. So, in summary, there are several challenges and there are several ways we can tackle them. But if we hold on to patients with good rapport, I think we can overcome much of these challenges. Thank you very much.
Thank you, that was excellent. We'll open up to the audience. Does anyone have any questions?
On the back.
Sure.
I think there's a mic in front. There's a
There might
mic
be.
in front, yeah, please. I think there's a mic behind the cameraman as well. Yeah.
I just have a question for the speaker. Given the poor affordability of patients in India and in Asia, as you speak in general, I'm just curious, you're talking about Eylea so consistently in your talk. What is the first injection that you recommend to patients when they come into your private practice? Let's say the patient is coming for the first time and he has wet CNVM or first episode of wet CNVM. So what will be the first injection that you're recommending in your practice generally? I just want to know that.
Yeah, I think the first anti-VEGF you will inject varies widely based on the country's funding, especially for patients that needed public funding assistance. Different countries have different sort of level of subsidy for different type of agent. in our country and in our practice, the standard drug we use is ranibizumab as a first instance. Then thereafter, we will go on to a scheme called Medical Assistance Fund, for which faricimab is now approved under this funding. And then we have MAF plus, which is aflibercept 2 milligram, 8 milligram. These are under MAF plus. So this is the sequence we use.
Thank you.
Thank you.